Hello, everybody. My name is Heather Brown. I'm a registered nurse and instructor at Gurnick Academy of Medical Arts. Today I'll be doing a video recording for nutrition on Chapter 12, Nutrition for Adults, the early, middle, and later years. So in Chapter 11, we looked at infancy, childhood, adolescence, and now we're going to go beyond that in Chapter 12. So this chapter will explore the ways in which positive nutrition can help adults to lead a healthier and hopefully disease-free life. Lesson 12.1, Individual Process of Aging. So each person experiences aging a little differently from one another. Gradual aging throughout the adult years is a unique process based on an individual's genetic heritage and life experience. So each person's going to experience this process differently. Life expectancy is increasing, so health promotion and disease prevention are even more important to ensure quality of life throughout these extended years. Adulthood, continuing human growth and development. So let's start by looking at some goals of Healthy People 2020. So some goals include high quality, longer lives, free of preventable disease, disability, injury, as well as premature death. So some population and age distribution. So by year 2060, the US population will be 416 million people. The number older than 65 will more than double by that time frame. So for you guys as up and coming nurses, this is job security. It shows that our population is aging. People are living longer. The median age will rise significantly from 36.9 years old to 42. So our population is going to be getting older. And that is a way for you guys to have nice and long nursing careers, but also people are getting sicker. So lots of different things here to consider in adulthood. Life expectancy and quality of life. So a little bit more in depth from the previous slide. So life expectancy is projected to be at 84 years old for men and 87.1 for women by that marker year of 2060. Of course, the age it varies among population as well as income groups, and Americans value health-related quality of life. Now we're looking at how that longer life expectancy is going to have an impact on healthcare and how it could potentially lead to career opportunities. So disease prevention and health promotion. So that's huge. Nowadays, you guys probably see a lot more on health promotion. So the goal now is moving from instead of reacting to when a patient, say, gets diagnosed with obesity and then saying, okay, now that you're obese, here's some things you should do. Now we're trying to prevent some of these things from occurring. We're promoting health. So there's a lot of jobs for nurses in not just health education, but health promotion. There's classes in healthy lifestyle and nutrition, sometimes taught by a dietitian, sometimes by a nurse. There's weight management and diabetes management type of courses, and also healthcare professionals that specialize in teaching those type of patients. So let's pause and talk about diabetes for a second. So a great strategy to educate your patients on to delay the onset of type 2 diabetes would be brisk walking. So brisk walking is important for a couple of different reasons, not just for the exercise part, but regular exercise delays the onset of type 2 diabetes because it increases glucose uptake. So imagine the sugar in your body in your bloodstream. Now, as you exercise, your cells will actually uptake some of that sugar, moving the sugar from your bloodstream into your cells for energy. So as the sugar moves out of your blood sugar decreases, therefore helping you prevent getting type 2 diabetes. So something like walking with friends for 45 minutes a day would be an example of something that somebody that works in health promotion or disease prevention would be instructing their patients on. So kind of interesting. For some of you, health promotion might be appealing. I know that it's something that interests me. it's also another reason why teaching interests me, is because I like to educate others. So some of you might find this to be an interesting field. Shaping influences on adult growth and development. So this diagram shows factors that influence the quality of life of adults who are 60 years old and older. So the term community includes health and supportive services at local or state or even federal levels, as well as health professionals and researchers. So you see a lot going on in here. So the quality of life is in the middle, and then everything that kind of the patient encounters is around that: independence, disease management. And then we see how the person, the family, caregiver, and community are kind of encircling this whole pattern. So shaping influences, the slide says, include physical, psychosocial, as well as socioeconomic concerns and their nutritional status. Physical growth. So levels off in early adult years. The focus shifts to replacing old cells. So let me pause here on that. So energy requirements decrease as adults age because the number of functioning body cells decreases with age. So now the focus is on just replacing old cells. So right below that, you see that energy requirements decrease. Remember, I said this is because the number of functioning body cells decrease with age. Metabolic rate gradually declines. At older ages, individual vigor reflects the health status of the preceding years. So that's just saying where somebody's been in their life as they age. You can kind of see how their earlier lives are affecting them as they age. So this slide is focusing solely on psychosocial development. So young adults aged 20 to 44, they're focused on independence, taking on new roles, life choices, and long-term health patterns. Middle adults, we're looking now primarily at ages 45 to 64. They're looking at opportunity for personal growth. They're refocusing on their life direction, and there's some early evidence of chronic disease. And older adults, we're talking 65 and older, outcomes here depend on a person's ability to deal with older age. So I'm sure you guys have grandparents or parents or family members or friends of family that you see that they have definitely a different outlook and how they process aging. So the outcomes for older adults definitely depend on how they deal with older age. Socioeconomic status. Pressures on food security, health, and finances. So our older population live on very fixed incomes. Like we said, they're living longer, and they are having a multitude of chronic health conditions. So that's all very costly on a limited budget. So there's definitely pressures on if they have enough food, their health is a constant pressure, and money is a pressure. These pressures, as well as loss of productivity, can combine to produce depression. So all this constant pressure of where they're going to get their next meal, their constant concerns over their health, and a very limited budget can lead to depression. So elderly patients with declining health are particularly susceptible to depression. So as a nurse, we screen everybody when they're admitted to a facility for depression. We ask them some standard questions, if they have thoughts of harming themselves, and do a general assessment. So you will unfortunately run into this a lot, especially with your older patients. As they're able to do less in their lives, they start to feel a little hopeless, like why are they doing it all? So I know I've encountered this many, many times in acute care, and it's something that I want you guys to be aware of as you move out into your careers, um, that this is a big element. There's also failure to thrive, unintentional weight loss. They don't usually intend on it, but all of these pressures, budget, um, and remember that their metabolism is slowed and they're not having those, creating as many cells. So they're usually not as hungry and they're usually not as interested in food. So we do see some unintentional weight loss in this population. Nutrition needs. Every person needs differing amounts depending on previous health and nutrition, as well as their current health and disease state. So just like when we talked in the previous chapter, how each individual is different, each person's needs are different. That's no different here. So it depends on their living and working situation. DRIs differ in 50 to 70-year-olds compared to those over 70. So think of that declining metabolic needs, and as they age, they just need less and less. Lesson 12.2, biologic, nutritional, social, economic, psychologic, and spiritual aspects of aging. So aging is a total life process that involves biologic, nutritional, social, economic, psychological, and spiritual aspects. Nutrition requirements change along with progressive physiologic changes of the body. So food and nutrition continue to provide essential support during the adult aging process. So now let's look at some of those biologic changes. So first, starting on metabolism, there's a gradual loss of cells, which results in lower metabolism. So I mentioned that on a previous slide. So that loss of cells, our metabolism now goes slower. A contributing factor to sarcopenia is inadequate dietary protein metabolism and physical activity. And regular physical activity helps to maintain muscle mass and metabolic rate. And next, the changes to hormones. We have a decline in melatonin. Decline in insulin often results in diabetes. So remember that insulin helps bring down the blood sugar. So as those insulin stores drop, we have a higher incidence of diabetes. There's a decrease in growth hormone as well as sex hormones. And menopause changes body composition. And a risk of chronic disease is also altered by menopause. So here we see a picture on menopause with some symptoms and physical changes. And then at the top, we have the impact of sarcopenia. So at the top. Effect on food patterns. GI secretions and motility decrease. So those GI secretions, as they decrease, food is not absorbed and weight loss or fatigue may occur. So those GI secretions lead to some other problems that we'll see in this slide. Also, motility decreases. So remember when we talk about motility or movement in the GI tract? So if that decreases, things don't move along as fast as they did. So we see more constipation, we see definitely a population that's very worried about their bowels because they're not going as much as they used to. There's also reduced senses that affect the appetite. So this includes vision, taste, and smell. So as a person ages, a decrease in the thirst mechanism occurs that can lead to inadequate fluid intake and therefore could result in dehydration. So the older adult also experiences this decrease in taste, smell, and vision, which affect food intake. So we have changes here to the vision, taste, and smell, all affecting how much they want to eat. And we also have that decreased thirst mechanism, which is all together putting them at risk for dehydration. We also have reduced physical abilities and hand function, as well as hand-eye coordination. So here we just kind of have a summary of some things that we've discussed before. So there's an individuality of the aging process. We focused on that throughout tonight's lectures, how it's a very individual process. Senescence is the process of growing old. Rate varies by the individual. Some people definitely age biologically much faster than they do chronologically. Rate depends on genetics and health, as well as nutrition of the past years. So this is just kind of starting to bring several of these lectures together, and we've repeating some of these key concepts. Nutrition needs. So now we're going to be looking at our macronutrients as well as fluids. So the BMR declines 1 to 2% per decade. So the decline in BMR means that less energy is needed for the body to function. So food intake should also decrease. So they need less energy. Therefore, we should be counteracting that less need by intaking less. There's a more rapid decline at age 40 years for men and 50 years for women. There's a gradual loss of functioning body cells and reduced physical activity. So we've hit on that gradual loss of functioning body cells a couple times in this lecture. The mean energy expenditure for women 51 to 70 is 2,066 calories per day. Not something that you need to memorize. This is just how much their bodies are working. For men in that same age range, 2469, and many factors affect energy and nutrient requirements. So once again, these couple of numbers on the slide aren't for you to memorize, just to kind of see what's happening here in the older adult's body. Macronutrients and fluids. So here's where we see our macronutrients, our carbs, fat, and protein. So let's start carbohydrates. This should be 45 to 65% of intake. Mostly should be complex carbohydrates. Next, fat. This should be 30% of their total intake. It's our backup energy source, fat-soluble vitamins, as well as essential fatty acids. Next, protein. This should be 10 to 35% of intake, or 0.8 grams per kilogram of body weight. And fluid, water needs relative to total energy needs do not decline with age. So their thirst mechanism declines, but the water that they need does not decrease. And then lastly, you can look at table 12-1. It's not something that we have on this slide, but you can reference that. It includes dietary protein recommendations for adults if you want to reference it. Once again, these percentages aren't for you to memorize, just illustrating how they should be dividing their intake between carbs, fats, and proteins. Also putting emphasis on how water needs are not declining with age. Micronutrients and health concerns. So a varied diet should be sufficient, but some conditions may necessitate special attention. So now we're going to be looking at osteoporosis. So why is this population at risk for osteoporosis? So the main thing here is inadequate calcium and vitamin D intake. So that's the big contributing factor here. So we see that here on this slide. Also, safe food handling practices are still important. So regardless of the patient's age, we always want to stress safe food handling practices. Nutrient supplementation. So after the age of 55, the DRI includes B12 supplements. Vitamin D supplementation may be needed. And we need to ask our patients to report and discuss the use of dietary and herbal supplements. So what that means there is anytime our patient's taking dietary or herbal supplements, they need to report it. When we're doing our medication reconciliation and we're finding out what medications our patient takes, we need to tell them that we even need to know about their over-the-counters, their herbal supplements, and whatever vitamins that they're taking. So we always want to stress that all medications, over-the-counter, herbal, or non, need to be disclosed to their healthcare provider. Clinical needs of the elderly. So health promotion and disease prevention. Remember how we talked about how there's more health promotion and disease prevention? So one of the goals was to reduce risk for chronic disease. So now we can look at that health promotion, how we want to reduce the risk for chronic disease, and tie in nutrition to that. So things like poor food habits, lack of appetite, loneliness, and lack of food availability really affect the elderly's nutritional status. So I'm going to focus on loneliness here. So an older adult is most likely to have an inadequate nutrient intake if he or she lives alone. So nutrients and where they live definitely impacts the elderly population. So those that live alone are most likely to have an inadequate nutrient intake. So think about it. Eating is a social process. So If they're feeling depressed and lonely and inactive, they have that decreased body requirements, they're not as hungry, they might not be apt to eat as much. Now, in a social situation, they see other people eating um, and they're just kind of chit chatting, and it provides them a better opportunity to eat. So, definitely here a focus on if they live alone, how that can impact them. Also, dental, missing teeth or poorly fitting dentures play a role in the nutritional status, which may leave them at risk for chronic disease, as well as general GI problems. So, decreased salivary secretions, inadequate hydrochloric acid in the stomach, decreased enzyme and mucus secretions, and decreased motility of intestines. So basically everything's slowing down. So as these things are slowing down, digestion doesn't happen as well. Bowel movements don't come as often. And then lastly here, dehydration. So we previously discussed how that thirst sensation is declining, but the water needs aren't. And oftentimes patients, especially our elderly patients, are at a high risk for dehydration. So let me emphasize before I move on the dental category. So here you see dentures. So dentures is huge. So I see this a lot in my patients in acute care. The loss of teeth or poorly fitting dentures definitely contribute to malnutrition in the elderly population. So we want to make sure that they have their dentures, that we're encouraging them to utilize them, that we're assisting them as much as possible and advocating for our patients because those dentures play a huge role in their nutritional status. Health promotion and disease prevention continued. So weight management and physical activity. So malnutrition or bad nutrition can produce either weight gain or loss. Remember that malnutrition isn't always being heavy, it can also being very thin. So malnutrition can produce weight gain or loss. It can produce overeating or undereating. Regular physical activity is a major factor. So remember I tied in how blood sugar depends on regular physical activity. So I gave the example of a great way to reduce the risk for type 2 diabetes being brisk walking for 45 minutes a day because it's going to move the sugar from the bloodstream and it's going to move it into the cells. So as the sugar comes out of the bloodstream, the blood sugar goes down. That's a good thing. That helps prevent type 2 diabetes. So that regular physical activity is a major factor. There's also a need for adequate protein intake. The risk of diabetes increases with age, which we've discussed already in this lecture, and an individual approach is required. Once again, that's a key concept. Treat each person individually and a personal sensitive approach. So remember that a lot of these different things are not easy for people to talk about or hear about. So we want to be very sensitive to our patients' needs. Here are some benefits of physical activity from box 12-1. So it helps maintain weight control. It reduces the risk of cardiovascular disease as well as type 2 diabetes, which we've mentioned a couple of times. Metabolic syndrome and some cancers. It helps strengthen bones and muscles. It improves mental health and mood. It also improves one ability to perform daily activities and prevents falls, especially among older adults. And it increases the chance of living longer. So we're probably pretty familiar with the benefits of physical activity, but here they are in box 12-1 for you to reference if you need. Chronic diseases of aging. Chronic diseases are not inevitable with aging and can be prevented. Here's a list of the common ones, the common chronic diseases of aging. Hypertension, heart disease, stroke, emphysema, diabetes, cancer, arthritis, and asthma. Once again, it's not inevitable that an elderly patient will get these. They can be prevented. And this is just a general list and not, of course, everything that they can get. So some lifestyle changes that can help prevent some of these chronic diseases would be regular physical exercise or activity. We've mentioned that a couple of times. Maintaining a healthy weight by making sure to choose a balanced diet rich in fruits and vegetables. Stopping smoking is another huge one, and limiting alcohol. These are all things that can be done to help prevent chronic diseases. These aren't all the things, but these are some of the big ones. Diet modifications. So we're going to look at diet modifications in chronic disease in chapters 17 to 23. So we're not going to focus on individual modifications much in this chapter. Just know that it's an individualized process. Medications for the elderly. So polypharmacy can affect nutritional status. So they take a lot of meds. That's polypharmacy, is many meds interacting together can affect nutritional status. Medications used by the elderly can affect fluid balance, appetite, as well as absorption of nutrients. We've already talked about how the aging process affects secretions and appetite and thirst. So we see now that their medications are also playing a role on them. And then lastly, we always want to ask about supplements or herbs. So I mentioned that a few slides ago, that we always want to ask them, even if it's over the counter, we need to know what they're taking, because they can interact with other medications and they just might not be aware of it. So we always want to be sure to educate them on the importance of always disclosing all of their medications, including supplements or herbs. Community resources. Government programs for older Americans. So poverty has a direct link to chronic diseases, and there's the Older Americans Act. So this is where we see congregate nutrition services. So these are like home delivered meals that have been approved for nutrient and calorie content. So they're set meals that are nutritious for the elderly population. So here we see the congregate nutrition services and home delivered meals. These are just some of the resources available for our elderly population. Community resources continued here. So more government programs for older Americans, including the U.S. Department of Agriculture. So we have research centers that focus on nutrition and aging. Extension services. So extension services are a nationwide program that are found through local county governments. So that's what it means by extension services. And then we also see here the SNAP program. So this is Supplemental Nutrition Assistance Program, or SNAP. It's formerly known as food stamps, and it's now more like debit cards, similar to debit cards, this SNAP program, formerly known as food stamps. So these are all different programs for our elderly population as well. So same topic here, guys. The U.S. Department of Agriculture continued. So we see Commodity Supplemental Food Program. This is food packages for eligible older adults. We see it a lot where there's brown bag pickups that include fruits and vegetables for the elderly population. There's also the Senior Farmers Market Nutrition Program. This provides low-income older adults with coupons for fresh produce obtained from markets or roadside stands. So when it comes to each of these programs, I just want you to know that there's resources available. Now, if you do decide to work in a health promotion or disease prevention department, you're definitely going to become a specialist in knowing each of these ins and outs. I just want to illustrate that there's a lot of resources available, and I want to encourage you, if you go into this field or you're working with the elderly population in general, that you make sure to let them know that there's a lot of resources available and help them discover them. So next we have the public health departments. So this is a division of Department of Health and Human Services. They work through local and state public health departments. So just lots of resources here for our elderly patients. Professional organizations and resources. The American Heart Association and the American Geriatric Society, these are examples of professional groups that help focus on older adult health. So once again, not groups that you need to memorize, just illustrating that the AHA, or the American Heart Association, This is an example of a professional group that helps focus on older adult health. So national groups, we have societies of healthcare workers, community groups, we have medical, nursing, um, dietetic associations, and we have volunteer organizations. National associations offer volunteer opportunities and resources. So much like I said in the previous couple of slides, I don't need you to memorize all of these different types, just illustrating that there are resources. Alternative living arrangements. So we have independent living facilities. So just like the name says, they live independently. These are for elderly patients who do not need a lot of medical care. They're able to take care of themselves independently. We also have congregate care arrangements. This is where we help keep our elderly in their homes, where somebody comes in and helps them, assists them, where that they can stay in their homes as long as possible. There's definitely been a switch where our elderly patients, they want to age in their own homes. And then there's also continuing care retirement communities. So this is a spectrum, so a spectrum of long-term care. So we have independent living to nursing care facilities. So this is where we see a community where it has an independent living section for when the elderly person could take care of themselves, not needing much medical attention. And then we have a progressive area where they could age to the next level, or say they have a health condition that requires them to get more care. So this is where they go from independent to perhaps a different part of the building where they need more nursing care facilities. So there's definitely facilities that allow for this continuing care depending on the elderly patient's needs. Alternative living arrangements continued. So we're going to start by looking at the assisted living facilities on this slide, known by several names. Right now I definitely see the words assisted living utilized the most. So this provides all meals as well as housekeeping and assistance with activities of daily living. So this is assisted living. It's meant to just give a little assistance. So we saw the independent ones for independent elderly patients, and now this is meant to provide a little assistance. But nursing hands on the other side, they provide the most medical, nursing, and nutrition support. So these are our patients that need a lot of help. So this is where they get assistance with their ADLs. So they usually need help showering, putting on their clothes. This is our most patients who need the most help. And there's usually dietitians on staff in these type of facilities. So one review slide here. So what we're trying to do here is tie in our macronutrient of protein with age. So let's look. The patient who would have the highest protein needs is. So go ahead and read these options, and then I will let you know. So think protein and why we need protein. What's the big thing that protein does, and which patient would need that the most? All right, guys, so the answer here is B. So remember, protein is needed for tissue growth and repair. So look at the possible answers here and think of the patient that's going to need the most protein for tissue growth and repair. So B, the 70-year-old man recovering from a broken hip. So lots of repair needed here. So this is our patient with the highest protein needs. The answer here is B. So I hope you all enjoyed this lecture. I hope you're all doing well. Thank you guys for listening in.